is all you need.
Yeah, thank you. Thank you very much. It's a privilege to be here. This is the title of my talk. This is what they gave me. Augmented fluoro is all you need. I put it in quotes because obviously I don't believe that augmented fluoro is all you need. But that's what I'll talk about. And I'm from the Cleveland Clinic too, and many of you probably know I'm Dr. Sethi's spouse. And since we're in Italy, it kind of reminds me of a very famous Italian couple. Dr. Gasparini, you know, se lo sai, right? Anyway, Sophia Loren, Marcello Mastriani. Anyway, these are my disclosures. I do work for Body Vision. I do work for NOAA Medical. Here, this is kind of, if anybody saw the live case yesterday, this is sort of what you see. You know, you think you're in the lesion, but, you know, maybe not. And boy, that looks stunningly like Chris Warden, doesn't it? It's not him, but maybe it's related. So anyway, you could see though, even though that you may in 2D fluoro look like you're in the lesion, you obviously, when you go out of plane into an oblique view, you're not. Again, you could see this illustrated by this video here. And I hope the sunlight doesn't wash this out too much, but you could probably see it better on the monitors. Look, this is a representation for just a cartoon graphic of what we were looking at, we were doing yesterday, where the blue dot is the nodule, the arrow is your biopsy tool or your scope, and the image that you're seeing on the fluoro screen would be this over here on the right. And you could see that if you're in front of the nodule, when you do your spin, right, your tool just moves out of range, right? We see that sort of all the time. We saw that a little bit yesterday during our case. So you could use this to help you target better, to understand where you are, where your tool is, your scope is in relation to the nodule. This is a kind of what we use if you do an oblique turn, if the nodule's on the right side and you do an oblique turn to the right and the needle moves to the right, then you're anterior to it. If it moves to the left, you're posterior to it, and so on and so forth. If you're on the left side, you're doing an LAO oblique turn, your needle moves to the left, you're anterior to it. So this is sort of a little thing that we have taped up. This I've had memorized, but it takes time to understand these things because new users are always used to what they've been used to, which is 2D imaging with fluoro. Not a lot of people spin their fluoro. Forward. Okay, so I'm not going to go through this. This is what Dr. Did I go? There we go. Dr. Sethi went through this before, so I don't need to tell you what digital tomosynthesis is. It's really cone beam imaging with a limited angle, right? And that's digital tomosynthesis. And if you have a wide angle, it's cone beam CT. But at the end of the day, you have X-rays, you're imaging something, and then you're getting projections, and then the computer is taking those projections, putting them together to create an image. And it doesn't matter if you have a flat panel digital like the Sios below or an analog that you have above like the GE9900. The important part is that all these images at some point get sent to a computer, either directly digital or through an analog to digital converter into a digital computer, and that's where all the magic happens. The magic happens in the computer, okay, which reconstructs the imaging the way you want it. It takes the data that you got from your spin, okay, the amount of data, which varies depending on certain things, which I'll talk about in a second, and it reconstructs your image. Now, what are the things that affect your image quality? Okay, and these are important to know because as you'll see in a second, you know, you can't always see nodules, so you need to be able to see them in some way if you can't see them in a standard fluoroscopic view. Well, the detector makes a big difference. You know, if the detector is small, 9-inch analog, it might be very different than, for instance, a flat panel digital, okay? So the detector is very, very important. The algorithm, the reconstruction algorithm becomes very important. The software behind these algorithms are just, they're insane. Go on LinkedIn, go on YouTube, you could see what some of these guys are doing in the world. With their reconstructions and the amazing reconstructions that they could get. And of course the sweep angle, obviously the larger the sweep angle, the more data you're getting for the algorithm to reconstruct. So again, this is why I think we need a augmented fluoro. I'm going to make a case. Now, boy, you really can't see this. You're going to see it on the monitors in the back. But what you're seeing here in the top image is it seems like you're lined up with the nodule, but when your needle comes out, this needle is going out and then deflecting underneath. If you have a target, an augmented fluoro target, and overlay on top of your image, you could see exactly where your needle needs to go for your biopsy. This is the beauty and the power of augmented imaging, of augmented fluoroscopy. So you're not just sending a needle out blindly. Now, yeah, most of the time your needle will go where you want it to go, but if it deflects like the top one, what do? How would you even know that's happening? So, and this is why we've created these platforms. This is, you've seen this an awful lot. This is the Body Vision Augmented Fluoro. Again, it uses 3D information derived from the tomosynthesis, okay, which enables us to fully appreciate the tools and lesion locations. We update lesion locations. We're able to get augmented fluoro. You could do this with cone beam. This is an image of Philips on the left. This is an image of GE on the right, Siemens in the middle, and I'm sure that by now all of these have been updated. That's okay. Thank you. So, I mean, we do the same thing with cone beam that we do with DT. So I'm not here to say one is any better than the other. You could do this with, you could do DT with a robotic scope. This is from Dr. El Reyes, one of my prior fellows, who's now in Wisconsin, or now Chicago. This is one of Dr. Sethi's cases. It looks like with a Monarch scope, as Dr. Kumbo talked before, using image targeting and augmented fluoro to kind of identify where she needs to stick her needle and where she needs to go out to. What else can you do with augmented fluoro? Well, I call this augmented fluoro plus. As long as you know where the where the nodule location is, yeah, you could do augmented fluoro and project it in real time over your live fluoro. You could also create a targeting screen as long as you have an idea where the tip of your scope is. So for instance, Body Vision is, they know where the tip of their scope is. They have an electromagnetic, not Body Vision, Galaxy. They have an electromagnetic sensor at the tip of their scope. They know where the location of that is. They know where the location of the nodule is. So I have now a targeting screen. You saw Kyle show this before. Why is this important? This is a case out of the University of Chicago. I believe this is Tim Mergu. And I think I have to hit that to make it go. And you can see, there's the blue dot, or the blue circle. That's his lesion in real space and in real time. And that's his targeting view above. They represent the same thing, by the way. The blue ball and that target view up there represent the same exact thing. So I'm able to target this, not just in 2 dimensions, but in 3 dimensions if I'd like. Sometimes, as you saw with the case we did with Michaela yesterday, we don't even need to do a tool and lesion sometimes. If you put the tool out and it's lying within that blue ball, and I spin, say, 15 or 20 degrees in a different angle, and it's still within the blue ball, I probably have 99–100% of the time I have a tool and lesion. I don't even need to do a tool and lesion spin. So it expedites my procedures. And if anybody has ever been in the bronchoscopy suite with me, they know I like to expedite. I don't like a 3-hour case or a 2-hour case. I want to be done as quickly as possible because I want to go home early. I'm old. I want to go enjoy life, like the Italians do. Okay. So let's talk a little bit about the data, because we should talk a little bit about the data, right? Because you go to these conferences and it's all in my experience and this is what I do, where I am. And so let's talk about the data just a little bit, okay? These are the first 2 published trials that came out just for Body Vision. And this was several software upgrades ago, okay? The first was from Mike Pritchett's group, and he did very well, just with Body Vision and augmented fluoro. He had a yield, you could see, of 75%, which is, pretty good if you think about what initial robotic was without imaging. This was our data from the Cleveland Clinic, roughly the same as Mike's. Actually, this is not just Cleveland Clinic. This was several sites. This was 5 sites collaborating together. This is our own individual data when we were collecting this, and you could see what Dr. Folk said yesterday, how technology advances yield. You could see that early on, our yield was about 75%, several upgrades, and we got our yield up to about 87, 88%. This is our Galaxy data. Now remember what a Galaxy is, right? It's just a robotic scope. It's a robotic scope that's doing everything that Illumicite and Super D and everything does. The only thing different is it's a robotic scope, which has fine articulation at the end. But robotics don't have location updating, and they don't have, and they certainly don't have augmented fluoro. The Galaxy does. So this is our data from this will be presented at the AABIP conference in Charlotte. Please come. You already saw Dr. Sethi's slide. Come virtually if you'd like, if you don't want to make the trip, but Charlotte is a nice place to be in August. Our average lesion size was 15.6. Our median was 14 millimeters. And to skip to the end, you could see our distributions and locations, 32% bronchosine. Our overall diagnostic yield was 92% using strict definitions. Okay? If you compare this to historic non-image guided robotic bronchoscopy, whether it's the ION, and the two best studies are Deckel's and Seaway Lowe's. Seaway Lowe's with us, Deckel is at MSKCC. Historically, without imaging, robotic bronchoscopy has somewhere between a 75 and 80% yield. Okay? That's the data. And when you add imaging, you drive that up to 90 to 95%. And it's not just with the Galaxy. If you had an ION and added imaging to the ION, which people are doing, several presenters already said that. They use ION with their imaging, with their cone beam. We use our ION, I like to use my ION with body vision, because the SIOS integration doesn't have augmented fluoro. The body vision does. I prefer that. I prefer it because it's faster. I think it's cleaner, but that's just my opinion. So, my conclusions. Augmented fluoro provides a powerful, I think, very important information for nodule biopsy. Is it the only thing? No. Obviously, there's other things that go into a successful biopsy, right? But the reconstruction algorithms that we're getting from 3D digital tomo, whether it's digital tomo, CABT, CBCT, really provide output capable of providing augmented fluoro, as well as what I think is really important, a targeting modality. I think it leads to better outcomes, leads to better yield. Data points, I think, to improved yields with integrated imaging, I think everyone here probably is going to agree with this. And augmented fluoro is just one component. And Joe Cicenia is a big fan of augmented fluoroscopy. Thank you.